So welcome everyone. Thanks for joining us today. We are really excited to have you join us today for joining us for part one of a two-part series regarding end-of-life conversations in home health and assisted living settings. I'd like to introduce today's presenters. First, we have Dr. Anna Beck. Dr. Beck is a director of supportive oncology and survivorship and an investigator at Huntsman Cancer Institute. She is also a professor of medical oncology at the University of Utah School of Medicine. She has been a community oncologist for 20 years and is the hospice medical director at Community Nursing Services, Home Health and Hospice, which received the Best in Utah awards for the past 5 consecutive years. She is board certified in internal medicine, medical oncology, integrative medicine, and hospice and palliative care. Joining Dr. Beck today is her colleague, Dr. Paige Patterson. Dr. Patterson is an assistant clinical professor, an academic palliative medicine physician at the University of Utah Department of Internal Medicine. She is a board certified physician in the specialties of internal medicine, pediatrics, and the subspecialty of hospice and palliative medicine. She has completed the Vital Talk Master Training and facilitated and taught communication skills training in the day-long course offered through this program. And in addition, she has taught at the Utah Certificate of Palliative Education and the Utah Communication Training, as well as facilitated several communication skills training courses. I'd like to give a warm welcome to Dr. Beck and Dr. Patterson. Thank you for joining us today.
Good morning, everybody. Thank you for tuning in. The title of our talk is going to be COVID Conundrums today. And these are some of the objectives that we would like you to have at the end of the course. We want to help you develop a skill set to confidently engage residents and caregivers in difficult conversations about COVID-19. We want you to empower your residents and caregivers to have an understanding about the prognosis if they were to contract COVID-19, and then to also learn how to elicit residents' goals as an opportunity to make a recommendation for treatment if COVID infection occurs. So those are our goals for today. So these are extraordinary times, and I don't think I am bringing any news to you in that regard. Our lives are all in upheaval, regardless of where you are and where you live. But you all are in a very special place right now in that you may be the main connection between your residents and the outside world, especially with respect to the COVID virus infection, which can be, significantly scary for each of your residents. So today what we want to do is try to help you have some conversations and help your residents be more prepared for what could happen to them personally if they develop a COVID infection. So why do we want to be proactive with these conversations? Well, first, patients and families want to feel prepared and they want to feel cared for. This virus has made all of us feel uncomfortable and awkward and vulnerable. So anything that we can do to help our families and our residents feel more prepared for the future is going to be valued. And as you know, our residents are fragile, and as a result of that, their health can change very precipitously. And furthermore, families also want to feel involved, and they want to have a role in caring for their loved ones, especially nowadays when oftentimes our residents can feel more isolated from their support systems and from their families. So the other part of this is that you guys are the experts in terms of helping your residents understand what might lie ahead for them should they become infected with the COVID virus. So it's up to us to fulfill that role as the experts. So what do patients with serious illness want, especially when we're looking at this uncertainty of a possible viral infection? Well, most patients say, I want my symptoms to be well managed. A lot of patients say, I always want to have good quality of life. Some patients will value quantity of life over quality. We don't know the answer to that, and that's part of what we need to sort out with our residents. And then lastly, most residents want to have some sense of control over what's going to happen to them. In reality, though, there can be this gap over what residents or patients with serious illness want and what they often get or what often happens to them in the future. So what we want to introduce today is a way to give them that sense of control once more in their life, or a sense of having a sense of control, let's put it that way. So how do we close that gap between what patients want and what they get? The answer is we ask patients what's important to them, to you, if they became seriously ill with a COVID virus infection. So asking them and learning about what's important will help us guide them for the future. So where do we as the caregivers fit in this scenario? Well, our goal is not to bully them, but to educate them. So a lot of times you're going to hear the phrase, we need advanced care planning, we need advanced care planning. And that doesn't necessarily mean that we're going to talk our residents or our frail patients into being DNR at any cost. It's more about helping them understand what the consequences of their decisions are going to be. So it's to educate them, not to bully them, not to make them choose what we think they should choose, but to help guide them based on what's important to them. And then it's also to make sure that they've got an advocate, a surrogate who knows and understands what they want and why they want it, and make sure that these wishes are well known. So we're going to introduce the COVID-19 Conversation Guide for Outpatient Care to help you guide through these conversations. Now, why do you need a guide? Well, these are emotionally intense conversations. A lot of the things that we're going to talk about center around what happens if things get worse for you in the future. And because everybody's gut kind of tightens when you talk about things that can be scary, it helps to have a bit of a teaching list or a checklist so that you know that you're proceeding in the right direction, so that you've got a skill set that you can practice, and that you make sure you cover everything that you want to cover in these conversations. So that's why we're going to introduce this guide to you. So these are hard conversations to have. I mean, even thinking about them, you might be feeling a little tense inside, like, wow, I'm not sure that I know how to help people understand what's important or to help them realize what their future might look like if they get an infection. So we're going to introduce some guidelines and principles to help you with these conversations. And the first is recognize that you're the coach here. You're the one who's the expert. You're the one who's going to be helping your residents get through the future. So your job is to help them facilitate these conversations, either thinking through them themselves or helping them advocate for their positions with their surrogate. So you're the coach, right? But you're not their judge. You're not going to say you're picking things that are not reasonable or unnecessary. Your job is to help explore what they want and understand why they want it, but not necessarily to pass judgment on what they want. Your job is also not to fix things. And if they say, well, I worry that my kids aren't going to want me around if I have an infection, or they're not going to want to come visit me, your job isn't to try to fix that sense of what's wrong. It's more to help understand, and instead keep going with the conversation about what's important to them dictates what they want in the future. So don't get lost in trying to fix symptoms like, well, I worry that my breathing will be too challenging to manage, or things like that. It's really to try to stay on track with the conversation of learning what's important and translating that into recommendations for the future. And then lastly, these are challenging conversations to have. And if you don't try to practice them, you won't ever feel a sense of ease or skill with them. So we're going to introduce these concepts, but we're going to challenge you at the end to really practice some of these conversations. And then when we come together next time, we can talk about things that didn't go well, things that did go well, and maybe problem solve or brainstorm areas that got a little dicey for you. Okay, so the first step is the setup. So this is a difficult and scary time with the coronavirus. I'm hoping we can talk about what's important to you so that we can provide you with the best care possible. So, and then asking, is that okay? When we say, is that okay? We're giving control of the conversation back to our resident or our patient so that they can say, yes, I think I'd like to talk about what the future might look like. That is something that I worry about as well too. It's not launching a conversation onto them without them being involved in it and giving consent. And then it may help to introduce why we want to do this. The goal is to make sure that we all understand what matters most to you so that you receive the care that you want and so that we can best support your family if they ever have to make decisions to you. So that's the way we set up the conversation with our residents or their surrogates. And then we assess what their understanding is. So what do you understand about how the coronavirus, if you were to contract the virus, how that might influence your health? Or you could say, what do you currently do to protect yourself from getting the virus? I've had some patients who say, I've lived a long life. I don't care if the virus takes me. It's not something that's important to me. If it means that my death is quick and painless, that's something that I'm not afraid of. If that's what they're feeling, that's again what we want to try to learn. And then we follow it up with, may I share with you my understanding of how the coronavirus could affect your health? So maybe they think that, the coronavirus, it's not that big of a deal, and if I get it, I'll be fine. I'm not that worried. Maybe they don't have a clear understanding of what the infection could mean for them. So offering to share what my understanding is so that we're all working from the same page and the same understanding. So that's the assess piece. The next piece is called sharing prognosis, and we'll talk a little bit more in depth about this in a few minutes. But the way we introduce that is to say, most people who get the coronavirus get better on their own. However, people who are older or who have other health problems like yours can get very sick and may not survive. The treatments that we use to try to help people live, like breathing machines, may not work. And if they do work, recovery from the illness may be uncertain. And then you pause to give them a moment to process all of that information. So when we talk about what the future looks like with coronavirus, this can be a lot for somebody to process, and allowing some space so that they can think through that is helpful. If you just keep going, you may lose your resident or your patient because you've given them a lot to think about. And if they don't get a minute or two to kind of unpack what you've said and make sure they've heard it all, you might just lose them in the confusion. So make sure you build in a few silent pauses there so that they understand. We really hope that you don't get the virus, but it's important to prepare in case you do. I think this is a really helpful statement in that you want to also make sure that this is a hopeful discussion and that you're aligned together in terms of making the future as good as possible for this resident. So we are hoping that you don't get the virus, or we hope that if you do get the virus that you have a full recovery. But it's still important to prepare about what's important to you, and that we're making sure that your wishes are well known. Okay? Given your underlying medical conditions, your diabetes, your age, I'd like to think together about what would be important to you if you became very sick or couldn't speak for yourself. So we take it onto a hypothetical plane where we can talk about what the future might look like if you were to get this infection and what it would look like specifically for you. And then we explore what would be the most important thing for your healthcare providers to know or your loved ones to know if you became very sick and couldn't speak for yourself. So what are you most worried about? Some of these questions will help them understand the things, or maybe offer up some of the things that they worry about or that they're fearful about or that they're hopeful for. What abilities are so important to you that you can't imagine living without them? I think this question and the what are you most worried about can oftentimes really grease the skids and help people really offer up the things that are guiding principles. So some patients may say, you know, I really don't ever want to be a burden to my family. If this viral infection leaves me so debilitated that I can't communicate with my family or interact with my family in a meaningful way, that's not the kind of life that I want to have. Or I'm already having some troubles interacting with my family. If this virus means that I'm lose that ability, that's not something I want to do. Or I've been in the hospital before. It was not a pleasant experience. If getting this virus means that I'm going to be hospitalized, then and be further away from my family or have to go through that experience, I never wanted to go through that again. So you see how these questions can kind of help residents and patients verbalize some of the things that are important for us to know if we're going to advocate for them. Other questions. If we think that we may be able to, if we think they may not help or cause suffering, some people make decisions to avoid treatments like being on breathing machines or having chest compressions if they get very sick. If that happened to you, have you thought about what medical treatments that you may or may not want? So those patients who have actually been on ventilators or been on breathing machines, if you will, sometimes both phrases are helpful for people to understand what you're talking about. Sometimes they have very strong feelings about whether or not they ever want to be put on those machines again. Or being in an intensive care unit. Sometimes patients have very strong feelings about being in an intensive care unit or being in a position where they're confused or delirious. So those are things that you want to make sure that you elicit before as you go talk about what the future might look like. And then how much do your loved ones know about your priorities? So in my particular situation with my parents, my mother always shared her wishes for what her end of life, what she wanted it to look like. She always wanted to be cremated. But my mother never shared those wishes with my two brothers. And when she passed away, my brothers got into a bit of a tug of war with me over what we should do because they never understood how strongly she felt about being cremated. And it wasn't until other members of the family stepped in and said, no, she's always wanted to be cremated. This is how her family they've been cremated for generations. And it was the fact that she hadn't passed that information along to key members of the family. It wound up being a source of conflict between my brothers and I. So we can help our residents because most residents don't want any conflict or distress to happen as these decisions that are being talked about. So if they can discuss them amongst all of their family members now, it helps everybody stay on the same page and feel confident that they're truly honoring what their loved one wanted. So then the last part is making a recommendation, and we're going to set that aside a little bit more so that Dr. Patterson can talk about that in detail because it's a really critical part of this conversation. Instead, let's talk for a minute or two about what the future might look like or what the prognosis might look like for your particular resident or seriously ill patient if they were to contract COVID-19. And this can be kind of a tough thing for us to do because most of the time we don't feel super confident about predicting what's going to happen in the future for our patients, right? So let's kind of talk through what that kind of a precarious situation might feel like and how we can help them understand it further. So key ideas. One of them is asking permission. Is it all right if we talk about what things might look like for you if you were to be infected with the COVID-19 virus? And in particular, the phrase that I use is what the future might hold for you. I tend to steer away from using the word prognosis because it's kind of a medical and a sterile term. And instead, I use what the future might hold for you or what the future might look like. I think that's a phrase that people find more helpful and more inviting. And then I say, what's your impression? What do you think? How do you think you would do if you got the COVID virus infection? And when they share that with you, it may tell you that they already get it, that they understand that it could be life-threatening, Or if they come across with, I don't know, I haven't thought about it, it helps you know where you can seat your conversation and what kind of information might be helpful. And then acknowledging that we don't know exactly what the future might look like. There's some uncertainty. When we talk about the future, sometimes people want to know, is this something that could take their life, or what their future might look like, what they might feel like after they've had the virus. And then we always want to embrace that hope piece. I'm hoping you would have a full recovery and feel just as good as you do now. I worry that given the challenges of your underlying diabetes or heart disease, your dementia, a complete recovery from COVID may not be likely. And I wonder if we could talk about what's important to you if your chances of recovery from the virus were slim. And then being prepared for emotion, because again, these can be intense things that they uncover, and patients may feel particularly vulnerable. So helping them understand that their fear or uncertainty are normal and giving them the space to kind of process through that is really helpful. So here's some numbers that may be helpful to know as you're talking to your residents. We know that roughly 50% of people who get infected with this virus may be completely asymptomatic, and that may be irrespective of age. Older people may have no symptoms related to the disease as younger people. But we also know that of the deaths from COVID around the world, roughly 25 to 50% of the deaths occur in the population that we find in our assisted livings and our independent livings and in our skilled nursing facilities. So our residents are the ones who are at greatest risk for dying from this infection. Who should worry the most? Well, age is a big part of it. We know that people over the age of 65 have an increased risk of dying from the disease. We know that men die more readily than women do. And we know that people who have underlying illnesses, like being people who are smokers, people with diabetes, people with cardiovascular disease, COPD, have a much higher rate of contracting the virus and having a poorer outcome. We also know that those patients who wind up in the ICU oftentimes don't make it out, and in fact up to 90% may die that are older and wind up needing intensive care. For those patients whose heart stops beating or who die, if they try to resuscitate them, the data that we have show that a very small percentage can be successfully resuscitated. And in the one study that looked at 136 patients who did get CPR, only one of those 136 patients actually left the hospital. So if CPR were to actually be used for a resident or somebody who actually passed away from this disease, the chances that it would restore them back to life is infinitesimally small. This is one guideline from the NHPCO, a national organization that kind of helps patients decide how they want to proceed with healthcare if they were to contract the COVID virus. And they help you sort it out based on their level of risk. Those at highest risk are those over the age of 80 and who have one or more chronic condition. Those who are at high risk from dying from the disease are between the ages of 70 to 79 and also have one or more chronic condition. And then those who are moderately high are over the age of 60 and have one or more chronic conditions. So what are those chronic conditions? Oh, let me just kind of skip ahead a little bit here. Their heart disease, their diabetes, their chronic lung disease, high blood pressure, certainly cancer. Those illnesses account for the chronic illnesses that put people at higher risk for dying. So discussing the future is scary. And remember, giving time for patients or residents to process some of this information that you're giving them is super important. So please take your time. And then responding to that emotion. I can see this is upsetting. Tell me more about what you're feeling. Or, you seem surprised. Tell me about what you weren't expecting to hear. Or, this is really hard. Tell me what you're thinking about right now. Again, learning and exploring what they're feeling so that you can help make those recommendations about the future. I'm going to now turn it over to Dr. Patterson so that she can talk about making recommendations.
Yes. All right. Hi. So we're going to talk about making a recommendation. And when I talk to, healthcare providers about this, sometimes this is the face I get. Make a recommendation. Me, I don't feel comfortable doing that. But I think it's important. I think it's part of our job as the experts to help kind of guide patients to making the right decisions based on their goals and based on what they know. So making recommendations based on the scope of practice. I think sometimes nurses, social workers, aides, therapists don't feel empowered enough to be able to have these conversations with patients. But I do want to say that anyone can initiate goals of care conversations. Anyone can recommend that advanced directives and/or a POLST form be completed. And if you're not a provider, anyone can recommend having further discussions with a provider and making, a good recommendation for having clear decision-making on code status. And I think the most important thing to remember is that anyone can advocate for the patient's goals. And that's kind of what we're all here for, to take the best care of patients. And part of that is making sure that their goals are clear and communicated well to those people that need to know. So patients may not be ready to make a decision and may need further discussion. Or patients may be ready to make a decision, but on varying levels. A patient may be ready to decide on a surrogate decision maker and may be ready to complete advanced directives. Or a patient may be able and ready to decide on treatment limits, or what we call kind of lines in the sand. So how do you make a recommendation? Again, our recommendations should always be made based on the patient's goals and with the patient's, best interests and what they want in mind. Like everything we do, there's certain steps that you can follow that can make this hard step a little bit easier. So the first thing you want to do is you want to summarize and align with goals. I understand that your goal is to spend as much time with your family as possible. Ask permission to make a recommendation. And I think that's important, and that can kind of alleviate some of the distress providers may feel about being too paternalistic if you're going to make a recommendation. So is it okay if I make a recommendation that you do this thing? And then make a recommendation based on the patient's goals. And we'll talk about how to phrase that too. And then you want to check in with patient, make sure that they are, that they understood what the recommendation was, and that that recommendation makes sense to them, and that it does align with their goals and what they want. So some way you can do that is by saying, thank you for sharing all that information with me. I'd like to reflect together on what we've shared and make a plan moving forward. Would that be okay? Again, that permission asking. I've heard you say that blank, I've heard you say that spending time with your family and being out of the hospital is really important to you. Based on your priorities and what we know about your illness and this current situation with the coronavirus, I recommend that if you were to get sick, we focus on making you comfortable rather than transporting you to the hospital. Does that sound right to you? Does that align with your goals? And it can be as easy as that. Just takes a few minutes to kind of make that recommendation. But I found that patients really value our input as the experts and appreciate having that guidance. So for people who maybe feel uncomfortable making a recommendation on treatment decisions, if a patient doesn't have an advanced directive or an identified surrogate, then I think those are things that are certainly within your scope of practice to recommend. So when you're making a recommendation on an advanced directive, acknowledge that these are hard conversations. This can be difficult to talk about, but at the same time, this conversation can help us ensure that what matters most to you guides your care if you get sick. I've heard you say that it's important to spend more time with your family than to be in the hospital. I think it's important to share this information with your loved ones so that they can speak for you if something happens and you can't speak for yourself. I recommend that we complete a healthcare proxy or advanced directive so that we know who to trust to make decisions for you if you can't. And going back again to checking in with the patient and reassuring them, this is an uncertain time for all of us. We will do everything we can to help you and your family through this. Making a recommendation for further discussion. If the patient does have some ideas about treatment decisions and lines in the sand, if you feel comfortable making recommendations on that, within your position in the healthcare team, then I think that's great. If not, I think, again, going back to being an advocate for the patient, making a recommendation to have further discussions with someone who is able to have those discussions is important. And not only making that recommendation, but actually helping make sure that happens. So, again, thank the patient. Thank you for taking the time to talk with me today. Think of continuing this conversation with the care team as a gift of love to help prepare those who care for you and love for you to know and honor your care decisions and preferences. So let's talk about the next steps. Can I schedule a time for you to talk with one of our clinicians to continue this conversation? And then checking in with the patient again. What questions do you have for me? And thank you for talking to me again today. I know that these are hard conversations to have. So what if the patient is ready to make a decision and they've, experienced this, they're pretty firm, they know what they want? Well, then you kind of have some decision points. So if the patient knows that based on their goals and risk levels, they want to be treated at home or in a nursing home, to be made comfortable and not go to the hospital, then you can make sure that those wishes are documented in a POST form and an advance directive. If the patient would want to go to the hospital, but would rather be focused on comfort, maybe is not interested in intubation, but would be interested in higher levels of oxygen support, IV fluids, or antibiotics, you can still complete a POST form and advance directive that documents those wishes. And then if the patient wants to be in the hospital for all life-prolonging measures that are available, then at least completing advance directives is really helpful so that that healthcare surrogate decision maker is noted and that the patient's wishes are noted, that they want to continue all life-prolonging or life-saving measures. Okay. And then for patients who may be ready to make decisions, recommend for or against life-sustaining treatments based on the patient's priorities and medical situation. So again, based on what you shared about what's important to you and your desire to avoid treatments that might not benefit and may lead to suffering, I recommend that if you get sick with COVID-19, it makes sense for you to be in the hospital, and we'll do everything we can to keep you from getting sicker and to try and make you feel better. But if you get worse and become critically ill with COVID-19, I would also recommend that we change the focus of your care to making sure that you're comfortable and that we don't put you in the ICU or on a breathing machine that may not prolong your life and may actually lead to more suffering. So after you've done that and made the recommendation, make sure you check in again. Does that sound okay to you? Does that sound right to you? Do you have any questions about this recommendation? Or do you have any questions about this treatment plan? How do you feel about that recommendation? And just asking them how do they feel, again, to check in on those emotions, because these are emotional conversations. Then the next step is to make sure that you follow up on these conversations, that the time and effort you and the patient put into having them are documented, and you can go forward. So whether it's an advance directive, a POST, you set up a time to have a further conversation with another member of the healthcare team, or set up a time to have a conversation with the patient's family member present. All those are important things to do to make sure that the patient's wishes are documented, again, so that you can be that advocate for the patient. And then thank the patient for having this difficult conversation. Okay. So in summary, the goal is for having a difficult conversation in the time of COVID-19 and learning how to make a recommendation are really to set up the conversation, to assess the patient's knowledge about their health and potential outcomes, and to educate them if necessary. To share the prognosis, to share the outcomes that may happen. To explore emotions, to allow patients time and space to process what may be hard to hear information. Silence can be your friend here. And then to make a recommendation that is within your scope of practice and that you feel comfortable doing. and then to summarize for the patient and make sure that those next steps are set up and followed so that this conversation is documented for the patient, for their loved ones, and for the entire healthcare team. So in terms of kind of putting it all together, Vital Talk has produced a lovely video that demonstrates how to have a goals of care conversation in the setting of COVID-19. Now, this conversation takes place between a provider in a nursing home and between a patient's family member who is at home. It is a telehealth conversation, as most of our conversations are these days, unfortunately.
Hello, Ms. McNally. I'm Dr. Bach from the COVID response team.
Hi.
I understand your father has tested positive for COVID.
Yes, I'm very worried, and I feel so guilty that I put him in a nursing home. I thought it was going to be a safe place.
You know, anybody would be worried in this situation, and there is no way you could have known this all would happen.
I suppose so.
Is it okay if we talk about what COVID means for your father?
Please.
May I first ask if you are the person who makes medical decisions for him?
Yes, I'm his surrogate, or whatever you call it. I have the papers.
Perfect. I just like to make sure I am talking to the right person.
Yes, that's me.
I need to give you some background. Most people who get COVID get a mild or moderate illness and don't ever need the hospital. The people who do get a severe case of COVID are mostly people who are older and have other medical problems, like your father.
Yeah, yes, I heard so much about that on the news, and I have been just afraid to think about it.
Well, that's a very normal reaction. COVID has put all of us in a tough place.
Oh, sorry. So I just want to pause there and point out the things that he's done so far. So he has, set the stage for the situation. He's checked in and asked permission to share some of this information, and then, normalize this. So responded to some of the emotion that the family member is feeling.
COVID.
Yes, I'm very worried, and I feel so guilty that I put him in a nursing home. I thought it was going to be a safe place.
You know, anybody would be worried in this situation, and there is no way you could have known this all would happen.
I suppose so.
Is it okay if we talk about what COVID means for your father?
Please.
May I first ask if you are the person who makes medical decisions for him?
Yes, I'm his surrogate.
Sorry, did not go forward far enough.
Background. Most people who get COVID get a mild or moderate illness and don't ever need the hospital. The people who do get a severe case of COVID are mostly people who are older and have other medical problems, like your father.
Yeah, yes, I heard so much about that on the news, and I have been just afraid to think about it.
Well, that's a very normal reaction. COVID has put all of us in a tough place.
Yeah, and I know that you're so busy.
We are doing our best under the circumstances. I hope your father has a mild case, and we can get him all the treatments that he needs. However, if the COVID does become severe, it would almost certainly take his life.
I was afraid you were going to say that.
It's not what any family member wants to hear. Given that, though, if the worst case scenario did happen and he was going to die, do you think he would rather be coming to the hospital or stay at his home? I mean his nursing home.
Whoa, that is a huge decision.
It is a big decision. I can see you want the best for him.
Absolutely.
Let me put it another way. If he didn't have dementia and he could sit here and be as sharp as you or me, and he understood what was happening with COVID, and he understood what would happen if his COVID got really severe, if he were sitting here with us, what would he say?
He would say, enough already, I'll stay here. But I don't know.
It sounds to me like if you put on his hat and speak for him, he'd say enough already. But when you put your hat back on, what you would say is, I don't know. Do I have that right?
Yes. I'm not ready to lose him.
Tell me more.
He's my dad, and he's always been there for me and my kids. He's the backbone of the family, and he has just always believed in me.
Would he believe in you now to speak for him?
Whew. Well, when you put it like that, I know the answer. I just don't like it.
It's not the kind of decision that anyone wants to make. It does sound like you two may have talked about this.
Well, when he told me when he was first diagnosed with dementia, like just slight dementia, forgetting, nothing big. We were driving in the car. We were going to go walk the dog, and he turned to me and he said, remember, when I can't do this anymore, it's time to let me go.
Wow. Thank you for telling me that.
I had kind of forgotten that. It's funny because I can actually hear him saying that to me.
That kind of memory is a gift. Would it be okay to honor it?
Now it's clear to me. Let's just keep him at his home.
Okay. So as you can see there, he kind of followed the steps of the meeting. So set up the conversation, make sure that he's talking to the right person, assess the patient's understanding, and provide some information, including prognosis about COVID-19 in her father. Additionally, he, explored what her father would want using a couple of different techniques. Asking, tell me more, to explore some emotion. Bringing the father into the conversation, saying, if your father were here right now and able to talk to us, what do you think he would want? And then, making those recommendations, like let's honor his wishes of staying home. Let's keep him in the nursing home. And then, kind of checking in with the patient and making sure that she's doing okay, thanking her for having these conversations and providing some validation for her, saying, yes, these are really difficult conversations to have. And yes, that's a powerful memory. What a wonderful gift her father gave her by having these conversations ahead of time. So over the next 3 weeks, we want you all to do a little bit of homework. Have 3 conversations with either a patient or a family member about goals of care. After the conversation, I want you to kind of take notes. Write down what you think went well and what questions or issues came up that you'd like to explore with the group. In 3 weeks, again, we're going to revisit these conversations in our next session and have a chance to kind of work through any issues or questions that came up, or to try new skills, things that you maybe felt uncomfortable doing in front of a person, but want to kind of role play and practice with some safe spaces here and some safe people. I would encourage you to kind of push yourself to have these conversations, not outside the scope of your practice, but feeling uncomfortable about these things is a sign that maybe you just need to practice a little bit more. All of us that have done this have practiced and practiced and practiced. No one is born being good at these conversations. But again, going back to all of us in the healthcare field are advocates for our patients. And this is one of the best things that we can do, to advocate that their voice is heard and that they're making informed decisions about their healthcare. So we look forward to seeing you in 3 weeks, and thank you all.
Thank you, Dr. Beck and Dr. Pattison, for your excellent presentation today. We really appreciate your time and expertise that you shared with us. And we're also looking forward to continuing this conversation in part 2 of our series taking place on June 18th at 10 a.m. This will be a live interactive session with both Drs. Beck and Patterson. After you've completed your homework over these next few weeks, you'll have the chance to provide, or this session will provide you with further opportunities to practice these new skills and ask any questions with the experts on this presentation today in a very safe and confidential space. The second part of this session will not be recorded, and it will just be a confidential live interactive training between Drs. Beck and Patterson and you all. So thank you both, and we appreciate your time today, and we look forward to joining us again on the 18th.